Thank you so much. I'm very happy to be here and just experiencing your amazing country for the first time. I would like to thank the Malaysian Music Therapy Association for making all of this possible. And the specific people that I've had contact with prior to this have been Indra, James, and Ming. Ming was my initial contact into this. So I realize that many others have been helping with this, and I'll get to know them, but those are the three who so far have, I know, put in a tremendous amount of time. I'm very happy to be here helping with this important event. My talk today is called Global Perspectives on Music Therapy, Turning Challenges into Opportunities. And I'm going to be talking first about my relationship to this topic. Then I'll talk about some challenges and opportunities. And then my experiences with some of those challenges, and finally the conclusions or the next steps. I'd like to just place myself with this topic. I know that people feel that music therapy is very well developed in the United States, and certainly it is compared to most other countries, but we're also very much, in many ways, in a very early stage of development, and I think that's something to be aware of, that we don't have music therapy in all the places that we should. We don't even have it in nearly all the places that we should. Music therapy is not paid for as well as it should be. There are not as many positions as we wish there were. So in all of the challenges that we're going to be talking about are things that we in the U.S. have dealt with and are still dealing with. I will be talking some about my at this point, rather long history with music therapy in the U.S. and some of the earlier stages of some of these issues that I've worked with. I also established, I was really instrumental in helping to establish music therapy in Louisville, Kentucky, one of the states in the U.S. And I will be talking about that a lot more pretty soon in my presentation. I'm also aware of how some other countries, especially European countries, are working to build music therapy. I've done some reading and just kind of maintain an awareness of what's happening in different countries, which I've drawn on as I've thought about this topic. And then I have some specific information through good contacts with colleagues in China and in Poland, and I've watched some of their developments and really current development of how they're developing. So I'm drawing from those things as I'm talking about these issues here today. The challenges and opportunities that I'm going to be going over include competing visions and associations, not enough music therapists, no educational institution for music therapy, no code of ethics, lack of established standards for music therapy, lack of government recognition, and a lack of good jobs. We'll take these one at a time. So the first challenge is competing visions or associations. And the opportunity there would be to communicate and agree so that divisions do not occur. I'm aware that you do not have this as a problem right now in Malaysia, and I'm really sharing this because I know that it could be a problem, and so I'm really alerting you that this is something I think to be aware of. I hope it never happens here. I have been involved in the U.S. and my history as a music therapist goes back to the early 1970s. So I go really back a long ways in the development of music therapy. Although I'm not part of the first generation of music therapists in the U.S., I am clearly a part of the second generation. We had two associations for many years, and they were formed in 1950 and I believe 1971, and for about 30 years after that, it was a real problem that people were hearing two different things about music therapy. And I'm very happy to say that in 1998, the two associations unified. Those previous associations were called the National Association for Music Therapy and the American Association of Music Therapy. And they unified in 1998 to become the American Music Therapy Association, AMTA. And that's the association you hear about now. So this other, for most people, is only a historical fact. But as someone who lived through it, I can tell you that it was not a pleasant process to have two associations or to get them to decide to unify. And again, I know that, or I understand this is not a problem in Malaysia now, and I just encourage Malaysian music therapists and others to keep communicating so that it does not become a problem. Another challenge is not enough music therapists. The opportunity here, I think, is to try to find ways to train more music therapists for more strength, and beginning a music therapy program at a university will certainly be the optimal solution. And that really moves to the next challenge, which is that there's no educational institution that currently offers a degree in music therapy in Malaysia. The opportunity here is to educate universities about music therapy and create a music therapy training program. There are other innovative ways of doing this, and I think that some of those will be considered because I'm very impressed with the creativity of the Malaysian music therapists that I have met. But this is a really important thing. And I'd like to just share my perspective from this, my experience. I've been involved as a consultant, I should say informal and formal, with a number of new music therapy educational programs. I started a new university program in Louisville, Kentucky in 2000, which is when I moved to Louisville, although the curriculum was already in place when I came, so I was not the person who actually was involved with convincing people to start the program, which is really another step. I think that Malaysian music therapists are working effectively to make this happen. I just want to emphasize that the final outcome is somewhat not under the control. It's not just that you have good people working or high motivation. It's, there are finances, there are different institutional cultures involved. So I do wish people the very best with this. I think it's a really, really important thing to have happen, to have an educational institution in the country. Another challenge is a lack of a code of ethics, which I understand does not exist yet. The opportunity here is to discuss ethical issues and create a code of ethics. My perspective on this is that in my years as a music therapist, not only the National Association for Music Therapy, but the American Music Therapy Association and the World Federation of Music Therapy have developed codes of ethics. And I've been a peripheral part of all of those developments. And it is not an easy job. It's a process that really involves developing a code, discussing the issues that are involved, because ethical issues are not simple. And then adopting and distributing the code of ethics. Ethical issues, I think sometimes we think rather naively, well, I'm an ethical person. I will behave ethically in my professional life. And hopefully we are ethical people and attempt to do that. But there are a lot of issues that come up as we think about what is involved in a code of ethics. Different professional things. What do you do with publication? What do you do when you're presenting information on a client? How do you present that ethically? And these are the issues that can be really important to discuss and can really take, I don't want to be discouraging, but can take years to work these out, and then will still need to be revised. But as you, as music therapists and music therapists who want to be, and other professionals, develop the code of ethics, you have an opportunity to think of all of these different issues and to talk about what one person feels is correct, to look at for instance, the psychologist's code of ethics. What are they saying? How might that differ from music therapists? And again, these are not simple issues, although they might seem initially very simple. Cheryl Dillio, U.S. music therapist, has done really important work, not only in helping all of these associations that I mentioned to develop their codes of ethics, but she's written one book, and I think it's being revised currently, on ethical issues in music therapy. And it really emphasizes how complex these things are. So I'm encouraging you to take this as an opportunity to look at some of the things that you believe and that fit with the Malaysian culture and determine the code of ethics. Ultimately, it does need to be adopted and then published so that people can look at it. the Polish Music Therapy Association, that I have very good contacts with, and I do some teaching in Poland, as Ming mentioned, has done this recently. And even in my teaching, some things came up, and we said, we're not sure this is right. So we went actually back to the person who had been primary in developing it, and I think, I don't read Polish, so I don't completely keep up with this, but I'm pretty sure they rethought some of this, because, again, they're very complex issues and important. Another challenge is the lack of established standards for music therapy. The opportunity here is to discuss and create standards, and in the process, there's better communication and agreement among music therapists. And I'm going to give you a little bit of my background, and then we'll talk a little bit more about this. The American Music Therapy Association, which I was president of a while ago, I guess 8 or so years ago now, has a committee called the Standards of Clinical Practice. And this committee works on an ongoing basis, and by that I mean over email during the year, and they meet every year at the conference. And they've done this for years to develop standards, to keep them up to date, to make sure that they're still feeling current. When people disagree with things, they consider them again. And the standards are then what we as music therapists can go to say, gee, I'm practicing in private practice. What should I be doing? How should I be, not what should I be doing clinically? That's a somewhat of a different issue. But what kind of thing, I'm going to use the word standards, do I need to uphold in doing this? Or I'm working with developmentally delayed people. What kind of issues will I confront? And in the U.S., this committee has developed standards for various different populations. And along the way, another population will emerge, and they'll then develop the standards for that. And to do this, they typically go to clinicians practicing in the area. They look at the research to see what the research shows. They then develop the standards. They talk about them. They pass them back to people. And ultimately, they're voted on by the body within our association that establishes policy. So again, like with the ethics, this is not a simple thing. And once they are established, we all can look at them. And there have been many times in my work with students and my own clinical work that I have looked at the standards and I've said, gee, we're not really doing what we should here. And so they can be very useful in that way. So I do see this as an opportunity to learn and figure things out. My own, again, experience with the AMTA Board of Directors, which I was on for 10 years prior to and during and then after my presidency, is that the Board of Directors gives also guidance to the Standards Committee. We may have heard about a new population that people were feeling the need for. So I've had really a lot of interaction with this kind of development of standards, although I have not been directly involved in it. I'd also like to talk about, in the U.S., the establishment of the Certification Board for Music Therapists. This is quite different from what you're doing in Malaysia. I have no idea if it would ever be important here, and it certainly is very premature here. But I would like you to be aware of it. Many years ago, I think in about 1990, and I was actually involved with the governance of NAMT at that time, we felt the need to have a separate body from our association that would credential people. And it was important from what we understood that this be separate so that there would not be any statement that there was bias. In other words, the association wasn't saying, well, here's what our schools are saying, and we're going to say that anybody who graduates from our schools is qualified. We needed a separate body. So we contracted at the time with a group which established the Certification Board for Music Therapists, abbreviated CBMT. And I think most of the people who have been aware of music therapy in the United States or studied there, most people end up becoming board certified, even though they don't need it. You do not need board certification in Malaysia, but it sort of says you've done what you need to in the U.S. And people who have done what the CBMT says they need to do become MTBC, Music Therapist Board Certified. So if you were to look back at the way I titled myself here, it is Barbara Wheeler, PhD, which is my degree, and then MTBC, because I'm music therapist board certified. This, and I know I'm repeating, but it's a sort of a different concept, is that from the separate group, the Certification Board for Music Therapists. Certification Board for Music Therapists is not an association. We do have to pay to maintain our board certification, but we're not paying to be part of this society or association. We're paying, again, a credentialing body. It says here it was established in 1983. I forgot I had put that when I said 1990, so apparently I looked that up, and it's even older than I remembered. The requirements for board certification are set by the Certification Board for Music Therapists. They're related to the standards. They're related to clinical practice, which is determined by surveys of what music therapists are doing. And I'm going to read here what the mission of the Certification Board for Music Therapists is. It is to ensure a standard of excellence in the development, implementation, and promotion of an accredited certification program for safe and competent music therapy practice. I want to say one more thing about that, and it really relates to the next area, which is government accreditation, and that is that in the U.S. we're working through the certification board to have accreditation of various types of music therapists in our various states. So the CBMT, Certification Board for Music Therapists, is very integral to music therapy in the U.S., but it is different from our association by intent. If we have time at the end for questions, and people have questions about this, which is a bit confusing, I can certainly answer them at that point, or try to answer them. Another challenge is the lack of government recognition. And the opportunity here is to educate government officials, which will lead to more awareness of music therapy, which will then lead to recognition and support for music therapy. And I'm involved as a member of AMTA, state associations, and some activity in contacting legislatures, including letter writing and activity in state legislature visits. I live in New Jersey now, one of the states of the U.S., and we are currently trying to get a license for music therapists. We have 50 states in the U.S., and each of these states has its own procedures for approval or accreditation. So it's not a simple process. Some states have already gotten licensure. Other states have decided licensure is not what they want. And as I mentioned a minute ago, we're in each case working with the board certification board people to use the board certification as the kind of vehicle to make the licensure happen, if it's going to happen. So I'm not really terribly active in this, but I try to do what I'm supposed to, writing letters to the legislatures, and then the legislature changes, and we have to write to new people, and so we're trying to get this to happen in New Jersey. When I was AMTA president, I made some presentations to increase lawmakers' awareness of music therapy. It is really a big process, and I think varies from state to state in the U.S. and country to country. I know that some of these things are happening here. A little bit more information about the U.S. I already mentioned that it's a state-by-state process. AMTA and CBMT have a plan to work with eventually all 50 states for recognition. Each state has its own process and is in a different place. So we have a couple of people through our association that are hired full-time to work with governmental relations. It's a big area. And when we read their newsletters, they have maybe 30 different reports from the different states. So there's a lot going on. I'm not going to bore you with all of the states, and I don't know about them. So, but it's a big process. Some of the states have task forces, some have plans, and there have been differing levels of success. And again, I know that some of this is happening here already. I'm impressed with what's happening in Malaysia. Another challenge is the lack of good jobs. The opportunity here is the creation of new and innovative positions. Always keep in mind that full-time positions with benefits provide the best foundation. This is my feeling, and I checked with Dr. Indra to see if she agreed. And she said, full-time positions in facilities that have an appreciation and understanding of what music therapy is and are willing to provide the investment and infrastructure to support the proper running of music therapy programs are the ideal. Now, that doesn't mean that we collectively are going to turn down any kind of music therapy position. And sometimes, frankly, part-time positions work better for various reasons. But I think that the more full-time positions with this support that are developed, the stronger you're going to find music therapy positions to be here. This is what I'm going to actually spend more time on because I think that the most substantial of my experience and what may be the most useful to you here will involve this. So my main experience that I think has been helpful to understanding this, was in Louisville, Kentucky. Again, that's one of the states in the U.S. I moved there in 2000, and there were music therapists working there. I would say somewhat like there are music therapists working here, and I would never want anybody to think that they were not, and they were doing very good work. But there was not much communication among them. There was not much... There was no organization, there was no state organization, and there wasn't a lot of recognition of music therapy in the community. There was somebody actually who did something that was not music therapy. It was probably quite valuable, but she was very good with public relations things. And almost everybody I met said, "Oh, I know a music therapist," and it was this person who was actually not a music therapist. And so that changed. That bothers music therapists a lot, and it was one of the issues that we had to confront and deal with. And I think we did. I probably just messed this up. Okay, I'm okay. So I came in 2000. One big difference was that I came to a university program that was just being established. I was there to start it up. I was the first faculty member. And that was really, really important, and I don't want to underplay the importance of having the university there. But the other experiences that I had there, I think, can be very relevant to here, and that's why I'm going to be sharing them. Some of the things that I did when I came to Louisville, I had a university program. I had about a dozen students who needed clinical placements immediately. And thankfully, one person was willing and able. My philosophy is always to have a music therapist in the facility who can supervise, as well as people from the university to supervise. It can't always happen, but that was my idea. For some reason, I was just very fortunate, and one music therapist worked in a number of facilities and was willing to take virtually all of my students that first year. I don't know what we would have done if she hadn't been willing to do that. After that, people would call up and they would say, "Gee, we have a great facility. We thought you might like to send some music therapy students here." Well, I know what that means. We want some free music therapy services. And I would very naively say, "Oh, yes, do you have a music therapist there to supervise them?" And they would say, "Oh, no, do we need one?" And I would say, "Yes, and here's how you can hire somebody for maybe just a few hours a week, and then as that person is working, they can supervise some of our students." And a lot of places became interested through this idea that they could get a student or two as well as their music therapy services. I think in some cases it hadn't occurred to them that maybe they were going to need to pay for music therapy. It's good to have people start to realize that this is a professional service. Sometimes we actually did send students to work under not music therapists, but qualified, competent occupational therapists, psychologists, special education teachers. And we would do that for a limited amount of time so that the facility could see how music therapy worked, and then made arrangements either to have them hire somebody, and again, this is where a part-time, few hours a week position can be really good, or we withdrew the services. So this is one way that I think it was useful to help people understand not only what the music therapist could do, but that they should start to think that this was a professional service that they needed to consider. I also supported my colleagues there, the music therapists that were working and building practices. I can think of several occasions where I met with administrators. It sometimes can be helpful for an administrator to know that this person is, Dr. Wheeler coming from the university or coming with different clinical experience. So that I think was also helpful. By the time that I left Louisville in 2011, I would have to say we had a very thriving music therapy community, which of course has continued. A little bit of a side note, the University of Kentucky, in a town about 60 miles away, had hired Lori Gooding to start a music therapy master's program there. Lori is one of the other speakers here. And so that was also a great thing, because prior to that, Louisville had been really the only center where there was music therapy happening. And I know that now, over the years, although Lori is no longer in Kentucky, there are 2 thriving centers for music therapy. So the difference from 2000 when I went and 2016 in music therapy in Kentucky, I think, is just dramatic. This is not all under anybody's control. Some of it was just good things that happened. One of the things I'll be talking about with one of the experiences that I had was that we just happened to hire somebody really good in one place that made a huge difference. So there are lots of things that you don't necessarily know you're doing. I told you already about this part, how I would use the clinical placements to help create jobs. I also told you this part about supporting the colleagues. I'm going to talk about 3 music therapy programs in different hospitals or medical settings in Louisville that I worked on. And I'm going to talk about Fraser Rehabilitation Institute, which was a rehabilitation facility where I started a small program that did not continue, and I'll talk about some of the experiences there. I'll talk about Baptist Hospital East, which was a program for oncology on an oncology unit that has a stable program with about 4 hours a week of clinical time. And then I'll talk about Norton Audubon Hospital, where the program grew and is thriving more than 10 years later. I'm going to talk about these not in the order of which, not in chronological order where I worked there, but in the order of success. And because what I'm trying to talk to you about is why some of these succeeded and why some of them didn't, from my perspective. And, among other things, you'll see that things do not always succeed. Again, this is my overview perspective. At the Fraser, the Rehabilitation Institute, my biggest thing that I learned from that was that I should have been documenting progress of my clients. I did not. I took that they would use the research that was available that said that music therapy can work with rehab clients, but I should have been documenting progress right along the way, and I'll tell you a little bit more about that. Baptist Hospital East has continued at about 2 or 4 hours. I think it's 4 hours, which is, I started with, I think, 2 or 3 hours a week. But it's at the same level now that it was 15 years ago. Maybe not quite 15 years ago, but 12 years ago or so. And I'm going to talk to you about why I think that was. I think it's because nobody was really pushing to make that program bigger. They've got some funding from people who donate money in memory of people that they are grateful for the help of the hospital, but nobody has pushed to make that program bigger. The one that has really grown is at Norton Audubon Hospital, where from the very beginning, a staff member who happened to be a chaplain pushed for the program to expand. And I think that is the difference in what's happened in the 3 hospitals, as well as a very fortunate hire that we did, which I'll talk about. So I'm going to now talk about the specific places. Well, first I'm going to tell you a little bit about what I did for each. In each case, I provided music therapy for about 3 or 4 hours a week. I was paid in each of these facilities. Some people do not get paid for this kind of thing, and I think that's also another way to do it. But I've kind of always felt that it was a good thing for people to plan to pay for music therapy services. So I was paid as a consultant to go and do the music therapy. I spent, as I said, about 3 or 4 hours a week at each. In each case, I included practicum students from the University of Louisville. So I was not only helping to train the students as the on-site supervisor, but they were able to provide more services at the facility. And in each case, I worked to educate the medical staff so that they knew more about what we were doing. I was really focused on how I would do some in-services for medical staff. And this varied from place to place. Sometimes they were sort of regular, ongoing in-services for nurses. But the one I'm going to focus on as I talk to you was when I got to meet with the physicians. And physicians are very important people, and they don't have a lot of time. They were not going to sit, at least in these facilities, and listen to me talk about music therapy for an hour. I had perhaps 15 minutes. And so I really maximized what I thought I could help them understand in that 15 minutes. I would typically do an overview of music therapy with a definition and helping them sort of see that we use receptive and live techniques and some of the things we did. I would typically do a little experiential, maybe some drumming with them or something like that. I tried to use a video or two that would give them an example of how it would work. And then I had pulled together some research from a meta-analysis that Dr. Jane Stanley did in 2000, and it was a medical meta-analysis. Meta-analysis being an analysis of lots of research studies, and then coming up with the medical areas in which music therapy had an effect. And I would pass this out on a handout, and I would give them the summary, and then I would give them the resources, the articles, that list of articles. I'm not sure that any of them would ever look up those articles, although it was possible. But I felt that it was good for them to have a whole list of sources that said that music therapy, this is research that shows that music therapy works. So I gave them handouts to take back. I gave them some things that they could remember. And I hope that I made the maximum use of my short amount of time that I was there. I think it's a very important thing to keep in mind. I did that at all of the facilities in various ways. So first talking about the Fraser Rehabilitation Institute, I was there from 2001 to 2002. As I mentioned before, I chose not to provide data on the progress of the patients. And this, I believe, was my error. I'm not saying that things would have been different if I had, but it was a thing I could really look to as a mistake. Later, they needed to make a choice between an art therapy program, and it was provided for children. I mean, how can you compete with children making beautiful artwork? But they chose that rather than my work with adults. And I really think that this was largely my error in not having the data. So the music therapy program stopped at that point, and I hope you might learn a little bit from my experience there. I then went to Baptist Hospital East, and what I'm showing here is I guess I have a couple of pictures here that were taken as part of a newspaper article. There was also a TV report that they did once on this hospital. This is a major hospital in Louisville. I worked on the oncology unit. It was funded by donations to the unit. As I alluded to earlier, people would give money in memory of people that they had on that unit that they were grateful for. I was there from 2005 to 2007. I worked 3 or 4 hours a week. Again, as I said before, I had done the in-services for the staff. I had interns there, or student practicum students with me. I provided monthly, this was what I learned from the first experience, I provided monthly data on patient responses. And I'm going to show you a little bit about what that data was like, what those data were like. The program continues today at about the same level. So here's how I worked on documenting the progress. When I would go to somebody's room, and this was all done in patients' rooms, I either was referred to patients by the nurses or a physician, or sometimes I would just see a patient who looked like perhaps they could use music therapy. I would go into their room. If it were a referral, I had an idea of why I was there. They were anxious or something like that. And I would ask them to rate 5 different things, and they're listed here. Rate your pain on a scale of 1 to 10, with 10 being the worst pain you can imagine and 1 being no pain at all. Rate your anxiety on the same scale. Rate your depression. Rate your level of stress. And then rate how relaxed you are. And the relaxation was reversed. A high number for relaxation was good. This is a visual analog scale, and I would therefore have these numbers for each patient who was able to give me the numbers. Some of them were not able to. I did this at the beginning of the session, and I did it at the end of the session. And I did it partly as an assessment so that I would know how they were feeling. I did it partly so that I knew if they felt any different when we left. And then at the end of the month and the quarter and the year, I would compile these numbers, and I would present them to the people. Thank you. I would present them to the people who were going to decide whether the program was going to continue. And again, this is what I think I learned at the Fraser Institute, where I was not presenting information. So if you look at this chart, you can see that the green is before the session, and the darker one is at the end of the session. And so they were pain, anxiety, depression, stress, and then the relaxation, which again is reversed. So every month, every quarter, and every year, they got this summary of this. And I'm not sure that this is the most important way to judge whether music therapy is making a difference, because it was before and after the session, and clearly often people would want me to feel good that I had done something. But it was the information that I was able to get, and I also think that it was very helpful for the staff, the decision makers, to realize that people were perceiving themselves as feeling better after the music therapy. Okay, and then the most successful experience that I had in Louisville in helping to create jobs was at the Norton Audubon Hospital, and here are just a couple of pictures of me there. This started actually quite shortly after I moved to Louisville, and there was a donor who had wanted to give money to buy CD players for the patients to have in their rooms so they could listen to music. You'll see more about her later, but her husband was a physician, and he didn't have music therapy, but he had been at a hospital in New York City and had these CD players and music, and found them very useful. And that's what she wanted to do. And it was very interesting. I would get these calls, and I was so sure that this was never going to materialize into anything. But it turned out, and this was from this chaplain that I mentioned, it turned out that every time she would contact somebody about how to proceed, she contacted a few music therapists who were well known, and they said, well, you know, Barbara Wheeler has just started a music therapy program at the University of Louisville. You should get in touch with her. So in spite of my predictions, they ultimately did get in touch with me and were interested in actually doing what I suggested. And as it turned out, from 2002 to 2004, I was able, I was after Fraser and before Baptist Hospital East, actually, I was able to do this work to try to develop music therapy there. So I did the same kind of thing there that I did in the other places. I started on my own with the 3 or 4 hours a week. I had students from the University of Louisville as practicum students, and ultimately, I had 2 copies here of the same page. Let me try to see a little bit different. Yeah. So ultimately, we had even a summer intern where the hospital hired a music therapy student for the summer. I would supervise. So we did a lot of things to help the hospital see what music therapy would be like. Unlike the first, what I talked about at Baptist Hospital East, which was only individual work, here we also had some group work, and we were working on a lot of the different units. They hired another music therapist after I left. I was actually involved in the hiring. Again, I was there 2 to 4 hours a week. The music therapist that was hired for 30 hours a week and later expanded to full-time. This was intentional. And one of the things that we asked her to do was establish a larger program. We tried to get reimbursement for the music therapy, which it turned out was not really feasible in the hospital setting. But her job was considerably different from mine. Hers was to expand the music therapy program. I can't even tell you how much she's expanded it. I am going to tell you specifics, but she's just done a magnificent job. Her name is Jenny Branson, and we were partly just fortunate that she was so good when we hired her. She currently has 9 music therapists serving 6 facilities as part of the Norton network. 3 of these are full-time, 3 are part-time, 20 hours a week, which is, pretty good part-time and they're permanent employees with benefits. So these are not, 2 or 3 hours a week people. These are really substantial. And then 3 are PRN, or as they're needed. So I am so proud of the program that has gone on there. And I don't attribute much of it to me. I attribute a lot of it to this original person, the chaplain, who was not only interested in having me come in and see what I could do, but was interested in how to build music therapy into the grain of the program there. And then I attribute it to having hired Jenny Branson, who's known what to do to make all of this expand. One of the very nice things that happened as part of this was we got some very good publicity. And what I'm going to show you is about an 6 or 8 minute video that was done by one of the TV stations. And it was so nice to have this acknowledgement of our program. It made a lot more people aware of it. And as you'll see, or I hope you'll see, it really pulled things together so that we could see what we were doing. We could, I think it's a nice presentation. I hope it's going to work here.
Henry Wadsworth Longfellow once wrote that music is the universal language of mankind.
Well, at Norton's Audubon Hospital, they're using music to help heal. It's part of a new program to honor a doctor who worked at the hospital for years. Music was both part of his life and his death. And our Rachel Platt joins us now to tell us more. Rachel?
Thank you all very much. His name was Robert Lerman, a pathologist at Audubon Hospital, who died 2.5 years ago from cancer. Robert Lerman always listened to music. He sang his pathology reports into his dictaphone. When he was diagnosed with cancer, music was part of his treatment and ultimately part of his death. Today, his love of music plays on.
He just saw the best in human beings, the best in humanity, in music. It was as important as, I think, brushing your teeth or, anything like that. It was just a part of his life.
From the start, music always struck a deep chord with Robert Lerman. He blended it into his everyday routine. Music and his love of the arts are reflected throughout the Lerman home. His wife Joni had no choice but to love music too. It calmed him, inspired him to paint, and in his death, comforted him.
He was just very contented. There was no, he was never anxious. Amazing grace.
Lerman's love of music lives on at Audubon Hospital with this music therapy program in his name. Once a week, U of L professor Barbara Wheeler, along with 2 of her students, uses music to make a connection with patients.
Okay, here we go. I want them to play on the beat. I want them to use it in some way where they're using them to enhance their awareness. Everybody ready?
Patients come to these classes feeling isolated, maybe feeling pain, even a little depressed. These particular patients have been in the hospital for weeks.
These people, of all the people we felt were here for the longest and had the least opportunity to really get out of their room and needed it perhaps the worst.
They needed harmony, so to speak, a musical lift. Clyde Hutchison underwent surgery for a chest infection. Irene Poston had a triple bypass at age 82. They say music was the perfect prescription.
And I hadn't thought about all this packing I've got around my chest right now. I haven't thought about how it hurts and how inconvenient it is. I haven't thought about something I've been here.
Not while you're singing.
Not while I'm singing.
It just fills your heart with melody and fills your heart with peace and calmness and gets all the worldly matters out of your mind.
Patients, their families, even staff members can come here to the second floor. This is the music library itself, named after Robert Lerman. Soft lighting, soft chairs, the perfect place to listen to music. In this room, music for the taking, for the listening, from the Backstreet Boys Millennium to Mozart.
Barbara Wheeler, I was music therapist who was here last week. Yeah, I know.
On the same floor, Barbara Wheeler has made her way to intensive care and to Nathan Eaton. The 19-year-old has a brain tumor and can no longer see.
I have a goal with him of increasing stimulation. He's so isolated in that room and so little stimulation.
Dr. Wheeler also wants to increase Nathan's emotional expression, to talk about how he's feeling.
What'd you have for breakfast or lunch?
Pancakes.
They write a song together about his daily routine. You Are My Sunshine turns into Nathan's song with Nathan's words. His mother comes in the room to watch her son light up.
Today I lay in there and read pancakes.
You try to sing and play the tambourine a little bit, and you just perked it up.
My mom was here and she loves me. I know music therapy is wonderful, and it just makes me feel so fortunate that I've been able to discover it and help people sparkle sometimes.
Music lifting the spirit and helping to heal. It's just what the doctor would have ordered. Dr. Robert Lerman.
He would love that people would be able to be touched by the music, whatever it is that speaks to them.
If you would like to contribute to the music therapy program in Dr. Lerman's name, you can make your check payable to the...
You don't have to know about making your check payable. Okay, so really my conclusions or the next steps are that challenges can turn into opportunities. Good planning can help, but not everything is predictable. Many people are needed to make progress. And just a note of encouragement, music therapy can grow. Here is my email address in case any of you want to get in touch with me for, I'd be happy to send a copy of this presentation, or it would not have the video with it, or anything else you'd like to ask me, and I thank you so much. We got started a little bit early, so we have 5 more minutes, or do you want me to end early, because I've taken my 45. Questions? If anybody has questions or comments, sure. Can you make it so that it goes into a microphone or something?
Dr. Insan, thank you for coming. Thank you very much. My name is Sabrina. I'm a rehabilitation physician. I'd like to thank the organizing committee and Dr. Indra for inviting you and your esteemed colleagues. My question is, we do in hospital rehabilitation, we do have a room called the Music and Movement Room, but it's very underutilized. We have a keyboard, a guitar, and a few percussions and a mat. So what my therapists usually do, we do not have a music therapist for your information. We have physiotherapists, occupational therapists, speech therapists, and audiologists, and we have physicians. So patients such as stroke, brain injury, amputees, spinal cord injury, it all depends on the therapist. If they are musically inclined, they will bring the patient to the room and do some light exercise. So with budget cuts and no increase in employing any music therapist, how do you propose for me to sell the idea to my superiors, especially the hospital director and the head of rehab, to incorporate whatever you have experienced in the 3 hospitals to make it work in a structured manner and collaborating with the existing universities and students? Thank you.
Sure, great question. Well, I really would encourage you to find a way to maybe get a consultant music therapist for just a couple of hours a week, not only to work directly with the patients, but to work with your staff to help them understand more about how to incorporate music with what they already do. Because nobody has the skills that a music therapist has in terms of really knowing how to utilize music to help people. But those other therapists that you have who are obviously very skilled in working with the physical problems and the emotional problems too, I'm sure, can then benefit from the music therapist's expertise and I would say expertise in terms of helping them and then even supervising them to make sure that they're still using the music correctly. You don't have to have a music therapist for many, many hours, although that would be ideal, but just a little bit to help those other people, I think, would be a great idea.
Any more questions? We have time for one more question.
Hello, my name is Jeffrey. I come from University Hospital up north in Kota Baru, and I'm the director of the Neuroscience Center. And we just starting our services to inculcate. We're not using the word music, we're using the word sound. We're not using the word dance, we're using the word movement. We're not using the word arts, we're using the word drawing. Because of cultural bias and religion bias. Because some people cannot accept certain type of music to be used for certain therapy because of cultural and religion bias. So I would like to listen to your experience. I know US is a different cup of tea, but Kelantan is also a different cup of tea, which is, I think our fellow Malaysians also understand the uniqueness of our problem. So, we are trying to use the traditional music instead of Mozart, for example, and instead of drawing using oil paintings and all that, maybe you have to draw something more local and cultural. And then the dance is very tough because certain dance can be done and some certain dance cannot be done. So I would like to hear about your experience. Thank you.
Right. I would like to emphasize that every place that I know, music therapists use music that's not just Mozart or classical, and it's always important that we adapt to the culture. I just can't really emphasize enough the importance of having some people who have actual training, whether you're calling it music or sound, whether you're calling it art or drawing, some input from people who have the training in how to use these modalities to help people. I just have never found a way to be helped by these modalities without having somebody with the training as the best way to do it. So my real input would be to get some input from people who have the training in how to use them, and then by all means adapt them to the culture that you need. I wish you good luck with it. Thank you. Thank you, everybody.
Thank you so much, Dr. Wheeler.